What are my shots?
So we are waiting just a couple minutes. We're still missing a couple of people here. And as soon as everybody's seated, then we'll get started. Yeah, Dean Halverson is speaking, so he'll be here shortly. Yeah, not first, but.
Oh, yes, we can hear. I thought
Yes.
maybe
Oh, yeah, I
speaking
don't,
engagement.
no, that could be true too.
Yeah.
Speaker series.
That's right.
National. We're starting in
I was still in
safety.
elementary. I graduated in 81.
Okay. This is very good.
Okay.
We'll try and then
Okay,
makes sense.
yeah, that's great. It's getting quiet, everybody must be.
I know.
Yeah, folks are formalizing.
I got it. I know. I know.
You know, we worked together years ago. We worked with it all.
So do we have- we-
Yeah.
We're missing two.
Okay.
So there's Dean Halverson.
There's the dean.
Yay.
All right, he's last.
And Dr. Welsh. Can probably start with that. How are you, sir? Oh, welcome.
Hello, stranger.
Hey. I always see you on Zoom these days.
I know.
Senator, nice seeing you.
Yeah. I know you did your job.
No.
Yeah.
Okay. Thank you. Can everybody hear me? Great. I'm Luke Kenley from Noblesville and co-chair of this prestigious commission here. And as everybody came in, everybody already had all the answers that we needed to have to solve this problem. They were so enthused to get to share them that I was just astounded. So I don't know if Judy and I are going to be leading or if we're going to just be following, but in any event, this is really exciting. Dr. Box, we want to thank you and the governor for your leadership the last few years, particularly with respect to the pandemic and other things that you've been handling. But we know that as a result of all those activities that you have felt that this is a time and this is a place where we need to take a serious look at our public health program in the state of Indiana. And if you think about the situation here in Indiana, we've had so many success stories in the last 20 years with respect to our tax system, with respect to economic development. The universities, we've put quite a bit of emphasis with them and invested a lot of money. And Indiana's universities are really seen very highly by most state universities around the country. And so we've had so many areas where we've had achievements. And yet, in terms of our own lifestyle, in terms of our citizens, the one area that we're probably lagging behind in is the health of our citizens and the health care of our citizens and the public health of our citizens. So I think that the governor was exactly right to follow Dr. Box's lead and request to establish this commission. I think the time has come that when you think about what is the share of the economy that is spent on healthcare compared to what it was 20 years ago, it's a huge change. And yet we haven't done much to upgrade, you might say, our performance or our program. So I'm going to co-chair this with your hopefully your kindness in allowing us to establish a procedure here. This will be something new to do, and I'm going to share the co-chairmanship with Judy Monroe. I'm going to give Judy a couple of opportunities to maybe make a couple of comments, and then we'll walk through some things here. And then, so Judy, welcome back to Indiana.
Yeah, well, thank you so much. It's terrific to be with all of you, and I just want to thank all of you all for your service joining the commission. It's a special privilege for me to join Senator Kinley and Dr. Box and Congresswoman Brooks. It's exciting to work with you again as well. So this is coming home to Indiana for me. And I also want to commend Governor Holcomb for his executive order to establish the commission and to charge all of us to take a hard look at the public health system here in Indiana and make recommendations for improvement. There's probably nationally no greater question right now. It's a burning issue across the nation. How do we improve public health? And so the leadership coming from Indiana is being watched. I will tell you that. I've had many other states call me after the announcement came out, wanting to know what's going on in Indiana. So beware, folks are watching. One of the things that gives me great privilege to be here is I do know Indiana pretty well. We moved here in 1990 with 3 small children, and I joined the Indiana University School of Medicine, and then after that went to St. Vincent Hospital, practiced medicine, and those clinical experiences here in Indiana gave me a upfront look at the excellence of medical care and the institutions here in Indiana. All 3 of our children went to IU, so we vouch for the quality of the universities. Following my clinical experience, I had the opportunity to be appointed by Governor Daniels to be your state health officer in 2005. And that experience led me to be able to interact with business leaders across the state, obviously the highest level of state government, academia, but also the grassroots leaders across the state. I traveled the state as health commissioner. I was commissioner during H1N1, so I've had a pandemic, not quite like this pandemic. So my hat's off to Dr. Box and everyone dealing with COVID-19. But I also saw the unevenness of public health services across the state during that time. And that's been a longstanding issue. One of the things I had an honor to do when I was commissioner was I was asked by, at that time, it was the dean of the medical school, Craig Brader, and provost of IU, who then later became president, Michael McRobbie, asked me to co-chair the task force to look at the feasibility of a school of public health in Indiana and whether or not we should do that. Now, my homework on that, before doing that, I learned that the health commissioner of the 1940s had recommended a school of public health be in Indiana. So it took 6 decades, but I was thrilled when IU determined and decided to establish 2 schools of public health. So we doubled the odds there, which was really exciting for me to see that all come to pass. And I give that as an example of, my hope for the aspiration of this commission is that we have such impact, that we have real impact with the recommendations in terms of taking place. Following my stint here, I did leave and go to CDC. I was a senior leader at CDC, and had the opportunity to work with health departments across the country. And I've also worked with the World Health Organization and I've had the chance to travel globally and see public health across the globe. So I bring those that new knowledge. I said I left Indiana. I had to leave for 11 years to get more education to come back to help. So I'm back with that experience that bring to the commission. And then for the last 5.5 years, I've had an opportunity to be the CEO of the CDC Foundation, which is a nonprofit organization established by Congress to help support public health and CDC. And in that role, I have worked with numerous business leaders, and because we forge public-private partnerships. And of course, no time like now in terms of the importance of public health to business. We need a healthy workforce. I think Senator Kinley outlined it well. Indiana's got so many strengths, and public health needs to be modernized. So I would just end my comments by saying, you know, someone, I don't know who it's attributed to, but it's been said that every system is perfectly designed to get the outcome that it achieves. And I would just charge all of us to think about what outcomes do we aspire to have in the state of Indiana, and then how do we design the system to get there. So
Thank you, Judy. And we are thrilled that you're willing to come back to Indiana and bring not only your Indiana influence from the years you served here, but since that time, and helping us with the leadership. So we're thrilled to do that. When Judy and Chris and I met, and we were trying to put together the members of the task force, or the commission, the governor's executive order provided for 3 elected officials. And so we had 2 picked out to represent local government in different ways. And we needed to have an odd number of commission members. And so it said 3 elected officials. And so we decided to begin already by stretching the rules. And the 3 of us decided that former Congresswoman Susan Brooks would be a perfect member for us. And so we are counting her as an elected official. But on the other hand, we thought that the best title that we could have is, we need somebody that here, we have all these special interests represented, but we need somebody that represents the people. And so Susan is going to represent the people, and the 3 of us cajoled and wheedled with Susan to ask her to do this. And I don't know whether she did it voluntarily or not, but I'm going to give her a chance to introduce herself and say a couple of words.
Well, thank you, Senator, and thanks for the calls, a couple of calls to me. And I'm really thrilled to be asked to be a part of this first commission. I have to say that when Dr. Box, who I have admired before she took on this role, when I went and visited Community Hospital's neonatal unit as a member of Congress during the opioid crisis, and saw her incredible dedication to the youngest of our citizens. When she asked, it's one of those things that's hard to say no, because you know that Dr. Box day in and day out is fighting the fight on behalf of Hoosiers. And then when I learned that Dr. Monroe was going to be coming back home to Indiana, my experience with Dr. Box, with Dr. Monroe came when I was U.S. Attorney from 2001 to 2007. And you all may recall, because we're coming upon the anniversary, not only of 9/11, but of the anthrax attacks across the country, and particularly in Washington. And as the top federal law enforcement official, we joined arms with the Public Health Department, Pam Pontonis in particular, as well, and educated law enforcement as to what a biodefense attack might look like, because no one was really familiar with anthrax attacks. No one was really familiar with, what those possibilities, whether they were naturally occurring or man-made attacks. And so I became a huge fan of public health. Very different from healthcare, but what the public health aspects and how important it was. Fast forward to becoming a member of Congress representing the 5th District, because I was so interested in the anthrax attacks, I took on a biodefense portfolio in Congress and became one of the Republican leads in the House on getting the reauthorization of all things, the Pandemic All Hazard Preparedness Act passed, which passed in 2006 initially, but every year or every 5 years or so that it needs to be reauthorized, it becomes improved upon. And so I talked with public health officials for years as a member of Congress, whether it was about the opioid crisis, whether it was about issues of obesity, whether it is about smoking, whether it is about biological attacks. And so I've had a lot of experience with public health officials. And little did we ever truly believe we'd need to really implement the pandemic all hazard preparedness ask. And we saw that we were short from the federal government. We fell short. We didn't focus enough on the supplies. We didn't focus enough. We focused on vaccines, but we didn't focus enough on the supplies. So as the citizen representative, I just want to share with you that citizens expect us all to do better. That's what they've learned through the pandemic. They admire how hard healthcare workers, your wife says an intensive care nurse, how hard everybody is working, but they expect government, they expect the private sector, they expect healthcare to all do better, and for us to come out of this pandemic. So I'm really proud to be a part of this, focusing on emergency preparedness, focusing on pandemic preparedness, focusing on workforce, because without the people, none of this can happen. If we don't have the right people throughout our state ready to lead our communities, and I'm not just talking about those in the hospitals and those in doctors' offices, but our public health workforce, that's what we've got to, I think, do a better job with. So just want to thank you for asking me to be a part of this. And I will do my best to represent the citizens of the state.
Thank you, Susan. We know you'll be great, and we appreciate so much doing this. And Chris, this is our first meeting. We're just kind of getting organized, and so there are some things that we sort of need to take care of. And Chris, I expect you to jump in and correct me and get me straightened out at any point. I will not feel insulted at all. So I will point out that Shane Hatchett is over here at this table, and he is the chief of staff for the Department of Health. And so I think we should all regard Shane as our personal resource to do whatever we need to have done. And so I encourage you all to get to know Shane. And then if we could, Dr. Box, I'd like to go around the room and let everybody just kind of identify themselves and maybe state where they're from, and then we can move on. And if possible, I think it would be, if all of you agree, I think it would be beneficial if Shane could get an email that you would like to have used, a personal phone number that we could use confidentially as commission members, so that we could reach out and talk to each other as much as we want to during that process. So if we could take a few minutes, Kim, why don't we start with you? Everybody here seems to already know each other. And I'm so glad that we're finally doing this, that I feel a little behind already. But anyhow, let's
Sure.
find out who's here.
And I'm going to leave my mask on. If it's not clear, let me know. Hi, I'm Kim Irwin. I serve as the administrator of the Indiana Public Health Association, and I am the executive director of Health by Design. I've been in that role about 13 years, and in public health about a decade longer than that. I do have a Master of Public Health from the IU School of Medicine prior to the creation of the School of Public Health. So I'm originally from Kendallville, Indiana, and I've been in Indy about 20 years after having left the state for a few years. So we're truly honored to be on it and look forward to participating.
My name is Kara Veal. I am the CEO with the Indiana Rural Health Association. I have been in this role for about 15 months now. Nothing like starting in the middle of a pandemic. But my background is clinical. I'm an occupational therapist, but have been in the hospital executive for about the last 9 years, and before stepping into this role. So I live in Washington, Indiana, about 2 hours south of here, originally from Brownsburg, just over on the west side. But have lived in rural for the last 15 years. That's what I know and love. And we are a statewide organization that partners with rural healthcare organizations across the state of Indiana.
I'm Brian Tabor. I'm president of the Indiana Hospital Association. We represent about 170 facilities across the state, not just acute care hospitals, but also behavioral health facilities, rehabilitation facilities, others. And I've been with the association for 13 years. Before I came to healthcare and the hospital association, I actually spent more time in kind of general public policy and fiscal policy. I worked with Senator Kemley in previous roles, and very glad to have you helping to steer this process. I'm originally from the East Coast, but came to Indiana to go to Purdue University. So go Boilers. Stayed there for graduate school and moved down to Indianapolis where I reside today.
Well, Brian, you have a little more gray hair, so I hope you have some, I hope you have some wisdom to add to this now.
18 months ago, I had none. It's been very rapid, very rapid.
Good afternoon, everyone. My name is Carl Ellison. I'm the president and CEO of the Indiana Minority Health Coalition. We're an organization that exists to eliminate health disparities. And while I don't look old enough, I am actually one of the original incorporators of the organization when we formed it in 1996. And sometimes with Tammy, I'll talk about how many commissioners I've known over the years, and they go back before the ones here. They go back quite a ways. So I've been kind of attached to public health for most of my career, although I have experience in government and consider myself kind of a safety net expert because I've run a housing authority, the WIC programs, community development block grant programs. I ran minority small business at the U.S. Small Business Administration for 2 years. So my career has been more trying to identify how to get improvements out of systems and how to get improvement out of programs that produce results for people. So I'm delighted to be asked to be on this commission. This shall be fun. I think we do have an opportunity to perhaps help reshape how we deliver public health in the state and improve health outcomes for all of our people.
Good afternoon. My name is Mindy Waldron. I'm the Deputy Health Commissioner with the Allen County Health Department. I act as the Department Administrator, and I'm also representing an association for the state, the Local Health Department Managers Association, that's comprised of health department executives, managers, administrators, and have been in that role for 15 years. This is my 31st year in public health. I worked in 3 health departments, 27 years in Allen County. And it's my passion. It's all I've ever done. So I think I'm representing the grassroots public health peeps, and go Hoosiers, because I went to IU.
Go Irish. I went to Notre Dame.
Probably started the thing. But I'm excited to be here as well. Nice to meet most of you, knew some of you, but great to meet new faces.
Good afternoon. I'm Mark Bardsley. I'm Commissioner in Grant County, Indiana, and starting my 5th term there as a commissioner. We actually began to put together preparedness during the H1N1. And so the things that we laid as a foundation 10 plus years ago were the things that helped us in Grant County get through that. And so from the beginning, we have a perspective that we want to share. We're excited about that. And other things that I do besides commissioner work, I have been public law enforcement as a chaplain for 31 years. And so we have some neat perspectives on public safety that I would probably like to kick into that information as well. Thank you.
Dennis Dawes. Denny is fine if you want to call me that. Dennis usually refers to Dennis the Menace. So I live in Brownsburg. I'm a county commissioner in Hendricks County immediately to the west of Marion County. For 40 years, I worked at Hendricks Regional Health, Hendricks County Hospital. 38 of those 40 years, I was president and CEO. When I retired from there, I ran for town council in Brownsburg and was elected to that, and then was kind of prompted to run for county commissioner. And I'm in my 1st year of my 1st term as county commissioner in Hendricks County. I feel like I've got some experience, background in healthcare, and hopefully I'll be able to help. I've known the Hospital Association for years, and actually Dr. Box and Dr. Monroe, when I graduated from Taylor University in Upland, Indiana, I went to work for the State Department of Health in the Division of Health Education.
Wonderful.
Yeah.
Good afternoon. My name is Bob Courtney. I'm the mayor of the city of Madison. Madison is the historic jewel of Indiana, located down on the Ohio River. So welcome everybody there. lived in Madison my entire life and part of this great Hoosier state. And I want to applaud the leadership that's happening here with Dr. Box and Governor Holcomb, looking for outcomes that will change the direction of our state. And I've only been mayor for a couple of years. In my prior life, I was in investment banking, but honored to serve the state, honored to serve the city of Madison and look for healthy outcomes. City of Madison actually embarked on a journey about 5 years ago and formed a Healthy Communities Initiative, and it was designed to look for opportunities to improve the public health of our community. And the health of our public and the health of our economy are so inextricably linked. You can't have one without the other. And I'm grateful for Dr. Box's leadership too, in working through this pandemic, and her accessibility and Shane's and the others and the team at the State Department of Health have just been phenomenal. And again, I think that if we take an intentional approach and data-driven, we can identify solutions. The challenge is going to be the human element of this. That's always the challenge, right? We can identify processes and accessibility and data and outcomes that we think that will work. Solution being very, very solution-driven. It's the human element that we have to really work extra hard to convince the public that this is the right approach. But I'm honored to be part of this, and thank you.
Dean Halverson.
Thank you so much. I'm Paul Halverson. I'm the founding dean at the Richard M. Fairbanks School of Public Health, and it's been a real honor and privilege for me to serve in that capacity as we started the new School of Public Health. And I've been here about 8.5 years, and I just want to say that Dr. Monroe and I actually became health commissioners, I think within a month of each other. So I was the health commissioner or state health officer in the state of Arkansas. And I served 2 different governors, two different terms, 8 years. So I've appreciated so much the work that Dr. Box and Dr. Monroe and others. In fact, prior to my time in Arkansas, actually, I served, and by the way, I served 2 different governors and 2 different parties. So I like to think of myself as political, but not partisan. So I think that's the way public health should be. And the other thing is, I would say that before I came to Arkansas, I actually was at the Centers for Disease Control and Prevention. So Judy and I also have a common background there. But I was thinking back, I think I've worked with 5 different Indiana state health commissioners because of that experience. When I worked at CDC, I worked was a director of the division that focused on state and local public health across the country. And one of our major areas of emphasis was in public health infrastructure. So I think I've had a chance to see public health in all 50 states and a number of countries. And I think that while we're not the first to be dealing with this issue, I so applaud and appreciate the great work that's in front of us. And I think it's achievable. It's going to be hard, but boy, I think it's so important for the people in our state. And I just want to close in saying how much I appreciate working with both Dr. Box and Dr. Kane. I have the privilege now of being able to be a dean of a school that was founded on the basis of wanting to be a supportive, to create a school that would really focus on the protection and improvement of the people of Indiana. And it's been our privilege, especially over the last 18 months, to support the great and important work that both the state health department and our county health departments have done in COVID. So look forward to working with you.
We're passing around a slip here. It says Governor's Public Health Commission parking ticket numbers for validation. And I parked in the State House lot. I weaseled my way in there.
That's, you don't have a number though for your parking ticket. If you have the parking ticket with you,
No,
put the number down. Then
No,
Tammy,
I
you
don't, but I'll pass this around. Anybody has a number, if they want to add it there.
Do they need the number on there?
All right.
Okay. In the future, we'll try to make that a standard protocol for you.
Dr. King.
Okay. Well, I really want to thank Governor Holcomb and Dr. Box for allowing me this honor to participate in this process, which I think can take Indiana's health to a new level. Believe it or not, I'm a child prodigy. And I was director and chief medical officer for the Marion County Health Department in Indianapolis, Indiana. And I'm a associate professor of medicine in the Division of Infectious Diseases for Indiana University School of Medicine. I primarily practice at our fourth largest public health hospital at Askenazi Health. And as a past president of APHA, American Public Health Association, I've had the wonderful opportunity of working so closely with everybody almost at this table, with the exception of a few officials. I know Dr. Monroe used to call me 6 o'clock in the mornings. And I couldn't figure that out. Working with H1N1, okay. And then unfortunately, Dr. Box would call me around about 11:45 in the evening, and she knows I watch Perry Mason from 11:30 to 12:30, and I don't like to get those calls. Only Susan Brooks call me at the appropriate time.
That's why you call me at
And making the
12:30.
calls, but whether it's the hospital systems or our local other health departments, our public health associations, and so many of my colleagues in this position, and even some young proteges that have just been out shining in their careers. This is a real honor to be part of this process. Thank you very much. And my co-partner here in my COVID-19 efforts as a technical consultant has just been wonderful. So thank you.
It's great to see so many familiar faces around the room. It's an honor to be part of this august group, and I thank the governor and Dr. Box, and it's great to work with Dr. Monroe again. Got to work with her the first time closely on the trauma care. Was it a task force then or a committee when?
I think it was a task force.
Task force, yeah. And you'd be very proud of the work being done. We're getting the state covered. I'm a general surgeon in Southeast Indiana. So when you're on your way to Madison, you can stop off at Batesville and say hello. And this weekend, it's going to be interesting between the Irish and the Boilers. I'm Irish. My son-in-law's a Boiler. But I'm real excited. Among my other hats I wear, I'm a county health officer. I've been Ripley County's county health officer for over 25 years and recently am now for Franklin County. So I've been learning a lot of stuff about public health on the job training, if you will. I'm also on the Council on Science and Public Health at the AMA. I can tell you, I've got my Bible for work with the Fairbanks review that was done. And that information was also being utilized by the Council on Science and Public Health at the AMA. We'll be coming out with a series of reports, the first one in November, on improving the public health infrastructure across the nation. And I can tell you they are very interested in our work, and they are going to be there to help us however we need them to help. Good public health is one of the pillars of the AMA. And also in recent years, public health has gotten on the radar of the American College of Surgeons. I'm on their board of regents, and maybe that's why, I don't know, I keep talking it up. And surgeons are learning that if we have good public health, their patients do better. So it's all about outcomes and measures and metrics. And if we have better metrics and better public health, the surgeons look a whole lot better. So I'm really excited. I know that this is going to take us places even further than the Trauma Care Committee, because it can reach so far. And I'm really excited to work with so many friends that I've known for a while and new friends. And there is no inappropriate time to call me as a general surgeon late at night. You call me anytime. I'll be happy to take it.
Well,
Thank you.
I know that everybody else knows you and you know everybody, but I don't know your name.
Oh, I'm sorry, Dave Welsh. Thank you. We've met before, but it was always with a large group from ISMA.
Thank you, Dave.
Hannah Maxey. I am honored and privileged to sit at a table with giants. And I'm honored to represent Health Workforce Initiatives in the state of Indiana. I currently serve as an associate professor of family medicine at the IU School of Medicine, and I direct the Bowen Center for Health Workforce Research and Policy. I think most importantly, I cut my teeth under Dr. Kane at the Marion County Public Health Department as a dental hygienist. So I had opportunity to see the clinical side implemented within public health settings. I was fortunate to be able to go on and receive a Master of Public Health and then finish my PhD from the Department of Health Policy and Management under Dean Halverson's watch. And in 2014 was very privileged to step into the role at the School of Medicine to work in partnership and collaboration with the state of Indiana on health workforce issues. I think the view of a clinical professional being trained in public health, understanding the system, and being able to contribute into both arms is absolutely critically important when we have conversations regarding workforce. And I'm just honored to be serving alongside leaders and people that I have looked up to for years.
Well, thank you all. Gee, you all are you already are so connected with each other. I feel like we should just go home and let Dr. Box write the report. We'll turn it in. There are a few, we're finding our way along here. So we need to have some procedures and some rules that we're going to work by. And we've laid out a few brief ideas. If you have some concern about something, why don't hesitate to contact me or Judy. You have some suggestions about other things, please do the same. We do have actually, we are pretty official. We do have a gavel here.
Okay.
And so we'll say that we have a quorum here today, and I guess we should establish a quorum as a majority of the members being here at any particular given meeting. And we will, if we need to, we will probably adopt some parliamentary rules, and I will check into that with the parliamentarian of the Senate to see if he has any recommendations for us there. When we do have discussions, I think that Judy and I will probably trade off chairing meetings at different times, but if any commission members have any particular questions, I would just raise your hand. We'll stop. We'll take them as we go. Brian, I think you'll recognize this is kind of the way we handle things in some of the committees in the Senate. And Susan was talking about how the congressmen like to make speeches. And so she wanted to know if everybody had a reserved amount of time so they could make their speech. We're not too accustomed to that yet. So, but we want you to participate. If you feel like you'd like to interject something, why just raise your hand to get our attention and we'll do that. We do look forward. There will be some times when we have commission meetings and it will be appropriate that we would have public testimony. We'll probably set up a procedure to do that. We'll probably establish some kind of a sign-up sheet or something of that nature to allow people to testify. And as a part of the overall initiative, we were hoping to have listening tours. It's probably going to be a little difficult right at this time to begin to do that kind of thing around the state. So if things open up and we have a better opportunity to do that, we will try to accomplish that in order to give the public an opportunity to testify and give their opinions. And then we'll probably have some kind of a format for just receiving public testimony. And then all of the policies and the recommendations that we will be developing over the next 16 months, why we will be discussing here at the commission level. We pledge that we'll have the best of transparency that we can provide under the circumstance, an open process, a full and honest discussion with an opportunity for everybody to speak. Now, having said that, I think all of you, as many of you public officials, are aware of the difficulties of public meetings right now throughout our communities. School boards are struggling. I hope we can get people to run for school board after the next couple of years, but we will expect, a certain level of behavior, a focus on the subject at hand, testimony with respect to the issues that are presented in the agenda. And we'll just deal with that as we go. But so if anybody has anything that they'd like to add to that, I don't know, Judy, do you have anything else that you?
No, I think you've outlined it well.
Okay. So moving on with the agenda, Dr. Box, the floor is yours, and then Dr. Halverson's going to make the presentation, and we'll have a little discussion about where we need to go next. And once again, I want to thank, and I know Judy joins me in thanking all of you for doing this. I was fairly scared the last couple of days about whether I was coming down here, taking on a new assignment after I already decided once that I was going to retire. But I am so enthused and excited by the level of quality and expertise that I see on this commission that I am just certain that this is the right step for Indiana in the next phase. So Dr. Box.
Thank you so much, Senator Kinley. Before I get started, I just want to take a moment to recognize that the work that we're doing on this commission is in part being funded by a very generous grant from the Fairbanks Foundation. So I really want to thank them for their engagement and also for their support. This past year and a half, dealing with the COVID-19 pandemic has further exposed, as you guys know better than I do, the difficulties that public health has faced in our state, secondary to workforce shortages, secondary to chronic underfunding, and also our aging infrastructure. The pandemic has also further delineated the racial and the socioeconomic disparities that the state of Indiana has had existing in our healthcare outcomes all across the state. I'm incredibly proud, and I don't ever want anyone to forget this, of the work that our state health, public health people and our local public health people have done across the state. They have done an amazing job. They're an incredible workforce, and it's really the most dedicated people that I've ever met in my life. And they truly care about their communities. So I want to make sure that we take a moment to thank them, but also I think our goal here is to help them. We need to help them to be successful in the delivery of public health services across the state. If we're going to build, as the governor says, the best state in the nation for Hoosiers to live and work and play and study, and most importantly, stay, then we got to focus on the fact that an individual's personal health and that our public health impacts not only our quantity of life, but our quality of life. It also affects our workforce, and it affects our healthcare costs in the state, all of which impact our state. In American history, gains in life expectancy and the quality of life have been attributed really to progressive investments in public health infrastructure. And I know that Dean Halverson will be talking a little bit more about this. But improvements in sanitation, for instance, in the 1800s eliminated cholera and typhoid in the United States, unless of course we go abroad and end up bringing that back with us. Immunizations have prevented mortality and morbidity with regards to measles, whooping cough, polio, and we now can almost prevent 5 different cancers completely through immunization. Addressing lead exposure in children by removing lead from paint and removing it from gasoline, and then just routine lead testing of children that are at risk. And that, along with fluoridation of water, all of these things have been numerous public health achievements that have made tremendous difference, not only in the quality of life, but quantity of life. Unfortunately, for the first time in generations, the life expectancy in the state of Indiana has been declining since the year 2010, when it peaked at 77.5 years. And Indiana's life expectancy, which is now 77.1 years, is actually 1.9 years lower than the US average. So almost 2 years lower than the US average, and places us 40th nationally. This is secondary mostly to our increases in drug overdoses, but also the increasing burdens of chronic diseases like diabetes and cancers and heart disease, which Hoosiers tend to die of more frequently. And that's related to our high obesity rates and our high smoking rates many times. In fact, the Institute of Medicine in 1988 stated that public health is what we do as a society, what we do collectively to assure the conditions in which people can be healthy. A lot of people get confused on the difference between public health and clinical health. Really, healthcare or clinical healthcare in the past has traditionally been known as referring to when we treat diseases or we treat injuries with the goal of restoring people to wellness. More and more healthcare systems, though, and healthcare professionals, they recognize the need to focus on population health, which, like public health, really has an upstream focus so that we can start to prevent illness and injury and premature deaths and prevent the spread of communicable diseases, which means that our clinical connection as public health with our clinicians and our hospitals and our clinics and our healthcare systems is a critical part of addressing public health. Unfortunately, rather than valuing prevention, our system has become increasingly focused on providing reimbursement to treat chronic disease and illness rather than preventing disease and preserving health. We know that public health is multi-sector and it has very outreaching impacts. So what we know and value and believe about public health is influenced by many factors. If we want to change behaviors and promote individuals into achieving their own optimal health, we must align our work through each of these spheres of influence. So at the individual level, the interpersonal level, a big part of that one is social media, which we've seen play out hugely with regards to our COVID-19 pandemic, to the organizational level, the community level, and the policy level. We have an opportunity to ensure health is promoted and valued at the global policy level, all the way down to the individual level, by increasing our understanding of and awareness and access. Now more than ever, it's important that we help people find good, trusted resources to make informed decisions about their health within their value systems. This model recognizes that by showing the relationship between communities, organizations, and close social networks and impact Hoosiers. The COVID-19 pandemic response has, in my mind, been a perfect response of the need to collaborate and partner across all of these sectors. We have partnered across state agencies, with nonprofits, with schools, with faith-based organizations, with state and local elected officials, our healthcare facilities, our institutes of higher education, and businesses across our state. And all of these partnerships, to my mind, must be memorialized and addressed as a part of integrating public health across our state. This slide from the Bipartisan Policy Center from 2012, I borrowed from Dean Halverson's report. It's busy, but it illustrates the imbalance of our funding for clinical care versus public health. Clinical care really accounts for maybe 10 to 20% of an individual's health, whereas the environment in which we live, like, is there lead paint in the paint in our home? Is there clean air where we live? Is there access to even be able to go to a park and to exercise? And also, is there transportation so we can get to clinical care and our jobs and our education? But other things like our healthy behaviors. Do we exercise? Do we eat healthily? Do we avoid unhealthy behaviors like substance use disorder and smoking? That makes up 70% of our health. However, 88% of what we spend is being spent on private insurance, like Medicaid and children's programs and private insurance. In fact, according to an April 2021 discussion paper by the National Academy of Medicine, which I provided each of you with today, because I think it's a really good look of how COVID really directs us to why and where we need to address problems in public health. But basically, according to them, spending on public health services is the equivalent of 1 to 3% of the capital expenditures that we spend on medical care. More importantly, a 2017 systemic review of the return on investment of public health interventions in high-income countries like the US found a median return of 14 to 1. As we investigate further the cost of Indiana's poor health metrics, Indiana, as you know, is one of the highest obesity rates in the country. 2/3 of our adults are either overweight or have obesity, and 1/3 of our children fall into these categories. This increases the risk for hypertension and diabetes, which then increases heart disease and strokes and many other issues, cancers and other things. Obesity alone costs more than $3.5 billion in medical costs, excess medical costs in Indiana. And obesity-related absenteeism costs U.S. employers more than $6 billion a year. Healthcare costs for obese individuals are estimated to be $1,400 a year higher than for those that are a healthy weight. This then translates into the higher costs that we see for chronic diseases. If you look at the CDC's information, 6 in 10 adults in the United States have at least one chronic disease, and 4 of 10 have 2 or more chronic diseases. Heart disease, cancer, lung disease, stroke, diabetes, kidney disease are all among the leading causes of death and disability in the US and cost $3.8 trillion per year nationally. Here in Indiana, the direct and indirect costs of major chronic diseases is nearly $76 million a year. We also are paying a high price at the state for the rate of smoking that we have among Hoosiers. Currently, more than 19% of adult Hoosiers smoke on a daily basis. This high rate of smoking leads to nearly $3 billion in annual healthcare costs, and a significant proportion of that is paid by Medicaid. We also see high costs of smoking during pregnancy across our state, as smoking increases the risk for preterm birth ×2. And conditions such as cervical cancer, which are mostly preventable now between vaccination and routine screening, are costing our state more than $54 million in direct healthcare costs. All of these conditions can be treated and prevented and result in significant savings, not only to the individual, but also to Indiana's taxpayers and employers. I want to share a U.S. News and World Report, which just came out in 2021, I believe in April. And Indiana ranked in that report 32nd out of 50 states, out of basically best states to live. They looked at 71 different metrics that were reviewed across the 8 categories that you can see here on the slide. Our scores in Indiana in education, in crime and corrections, the economy, and opportunity all placed Indiana in the top 25 states. Unfortunately, our health scores, specifically our public health scores, consistently placed Indiana in the bottom state at 20 states. Actually, most of those metrics placed us in the bottom 10 states. These are just a few of those scores from that report. And as you can see, workforce, Dr. Maxey, was one of our major issues, with mental health workforce, primary care workforce, and oral health, all being issues for the state of Indiana. Our public health funding put us 48th in the nation. Immunizations overall for adults, 48th, and childhood immunizations at 44th. And as you can see, smoking, obesity, diabetes, and chronic pulmonary disease, all above 40th, so in the bottom 10 states. Additionally, according to America's Health Rankings in 2018, Indiana's overall public health ranking of 41st out of 50 states actually is the lowest of all of our neighboring states, with the exception of Kentucky, that was 45th. According to Indiana's public health scores, if we're going to match our excellence in education and economy and overall opportunity, this is going to require the fresh look at public health in the state of Indiana that we've been talking about. Not only looking at the structure of public health, but also the services that we deliver, the equity of those services that are delivered across our state, and how we can make sure that we have not only sustainable funding and sustainable local public health, but also that sustainable workforce that we need to actually staff that public health, those public health clinics. And we also need to create and continue those cross-sector partnerships to better position ourselves to address our next public health crisis. But before we envision how public health appears in our future, we really have to understand how it currently exists and what it looks like already in our state. Indiana's public health system has not been significantly modified since 1992, when the State Board of Health became the Indiana State Department of Health, now known as the Indiana Department of Health, and local health boards were created across the state. Our public health statutes are aging and built on a model that is really no longer meeting the needs of all Hoosiers across our state. As you can see, our current structure includes our Indiana State Department of Health at the state level. Our local public health is decentralized, or what we call under local control or home rule. It consists of 94 local health departments with exclusive jurisdiction for delivering those public health services in their respective areas, whether that's in a county or a municipality. There are 90 individual county health departments. There are 2 counties that are combined, that's Fountain and Warren. And we have 3 municipal health departments, Gary, East Chicago, and Fishers. Currently by statute, second-class cities may, and I didn't give them the name second-class cities, that's in statute. It has to do with the population. It actually, basically, they may establish their own local health department. Hammond used to have a local health department, but voted to abolish it in 2007 after no longer being able to continue to fund that. Dr. Halverson will show you how we have extensive disparities across the state in funding, staffing, and resources to support these essential public health services that are required by the state. Every local health department must perform dozens of statutory and regulatory functions, some of which are listed here on this slide. Regardless of their size, their funding, their staffing, all 94 health departments must by law perform these statutory and regulatory functions. Depending on the size of different local health departments, these obligations are often fulfilled differently across the state. Oftentimes, sheer lack of funding, resources, and workforce prohibits many of our local health departments from fulfilling these requirements completely. And I saw this firsthand because one of the first things I did was go out to all of our local health departments and meet as many local health officers and administrators and public health nurses as possible so that I could see the differences that exist. Potential restructuring of our current public health infrastructure in Indiana can address existing disparities in public health services across our state, so that where you live in Indiana does not determine the public health services that are available to you. The governor's approach to transform public health in our state is to form this expert public health commission through the Executive Order 2121. We are honored that you have taken the time to join us. I know I said to Mindy, we always choose the busiest people to join these types of committees because we know when we go to the busiest people, they get the work done. They are engaged with other people and they will serve and work very hard to get to the goal that we are all trying to reach together. We are also very honored to have the expertise of our two chairpersons, Dr. Judy Monroe and Senator Luke Kenley, and our citizen advisor, Congresswoman Susan Brooks. So we thank you all for your time. The executive order mandates us to generate a report by late next summer for the governor that will analyze our current public health system, including its strengths and its weaknesses. We are going to make recommendations to improve the delivery of public health services, addressing funding challenges, making sure that we promote health equity, and ensuring the sustainability of our local health departments and local public health for the future. He also directs us to analyze the state and local health departments during the 2019 coronavirus pandemic and to make recommendations to ensure that Indiana is well positioned for any future emergencies. And lastly, but still importantly, to propose draft bill language which reflects these recommendations for the potential of our 2023 legislative session. All of the actual policy, as Senator Kenley said, will actually be made here at the commission level. It will be a very transparent process and a very public process. We will rely on the research and policy analysis done by what we call designated policy advisors, which I will go through in more depth in just a moment. Along with the research and policy analysis, additional input will be solicited from groups of individuals in working sessions. And we will be happy to listen to any individuals that would like to give input on this. The DPAs will then present findings at these monthly commission meetings for consideration and deliberation and discussion. Our Indiana Department of Health Chief of Staff, Shane Hatchett, will be the designated lead for the Department of Health, and we will make sure that we have given you his email address, so all of you will know how to reach him. The areas of focus and designated policy advisors are listed here, and they will focus on these 6 work streams so that the commission has sufficient research and topical knowledge in key areas of public health. As you can see from the slide, and I think we have Director Fox here. He will be our policy advisor for emergency preparedness. Pam Pontonis, our Deputy Health Commissioner, will be our policy advisor for governance and structure. Shane Hatchett will be our policy advisor for funding. Good luck with that one, Shane. And Lindsay Weaver, who could not be with us today, but is our Chief Medical Officer, will serve as the data and information integration analyst. And she is already working across state agencies with a lot of money that has been given through grants from the CDC to address public health infrastructure with regards to our information and data sharing. And healthcare and public health workforce will be through the Bowen Center. Dr. Maxey is here. And our childhood and adolescent health integration will be through FSSA's Chief Medical Officer, Dr. Maria Fennell, who is also with us today. And I wanted you to be able to put names and faces. It's now my distinct pleasure to introduce Dr. Paul Halverson, who, as he said, is the founding dean of the Fairbanks School of Public Health in Indianapolis. Prior to joining the Indiana University, Dr. Halverson served as a state health officer, and he has been a wonderful mentor and advisor to me through everything that I have gone through in the last 4 years, and I appreciate him immensely. He will be sharing part of the Fairbanks School of Public Health recent publication entitled Indiana Public Health System Review, which we gave you a copy of before this meeting, and we hopefully all of you received that. The recommendations and information in this report may help to provide a template as we review additional data points and additional options this next year. Dean Halverson.
Thank you, Dr. Box, and it's great to be able to offer our report sort of as a launching pad. I think it's a place to start. This group will need to chew on a lot of issues, and my hope is perhaps this will give some grist for the mill. I just wanted to also say how much I appreciate Dr. Box. In public health, we never know when our number is up, in terms of the activities that we embrace. And Dr. Box at least got a couple of years without COVID or problem before it came. I was reflecting, and Dr. Monroe, I think, can identify with this. When 9/11 happened, I was at the CDC, and I recall that the new state health officer for Florida had been in his job for, I think, 6 days when he was asked and kind of thrust into the midst of the anthrax attacks and trying to explain to the world what was going on. And he would be, Dr. Agwanobi is his name. He went on to be the Assistant Secretary of Health and has done a marvelous job. But he would be the first to tell you, he didn't know much about public health, but it was sort of baptism by fire. And that, unfortunately, is kind of the way things happen in public health. And so in any regard, I'm pleased to share with you this report. I should also tell you that, like the support for the commission, the Richard M. Fairbanks Foundation commissioned this paper. And I want to give a credit to the foundation because their interest, Mr. Fairbanks, as a philanthropist, many of you perhaps may have known him for his work in Fairbanks communication and all of the work that he did before he passed. But in establishing the foundation, their mandate is very clear. Mr. Fairbanks' interest was in the health and vitality of Indianapolis and Indiana. And so our hope is that this work will honor his interest and the interest of the foundation and ultimately have an impact on the health of all of our citizens. So this work was led by myself and Dr. Valerie Yeager, who is an incredible researcher. We had a couple of important consultants that I would draw to your attention. Glenn Mays is probably the lead author on more papers in health, public health systems research of any author, any scientist that's done work in this area. And he's worked extensively with the Institute of Medicine and other national organizations. And Dr. Tilson is both a physician and a public health official, having been state health officer in North Carolina and local health officer in 2 different locations, including Portland and in Maine, and has served in many important positions. He has also written extensively, and both of these folks are very involved with this research, and I appreciate their efforts. I will also tell you that this research came with the active engagement of over 50 people that endured sometimes an hour or more interview. In fact, I think a few of you were part of our research where we sat and visited with you. We talked to CEOs of major companies, from people from all over the state, in large companies and small companies and chambers of commerce and so forth and so on, as well as health officers, both at the state level and local level, and as well as policymakers. So we tried to cover a wide ground when we did this work. We think that really COVID-19 sounded the alarm that Indiana's public health system, of course, as you know, is chronically underfunded and undervalued. And let me give you an analogy. And, you know, we try to find, and again, I want to emphasize that point that Dr. Box made, because I don't want anyone to misunderstand. I'm going to talk pretty honestly and plainly about the shortcomings of our public health system, but I don't want to infer for a second that I have any ill will towards the wonderful people who work in public health every day. This is their mission. And they're like the soldiers that, you know, sign up to be in the Army or to be to represent and defend us. And unfortunately, as a state, I think what we've done is we've got a great Army with terrific people, and we've sent them out to battle without bullets in their gun and with a ragtag amount of equipment and with the inability to be successful. And I can't emphasize enough how I think we need to, as a state, recognize our responsibility to properly fund the public health system so that it actually can do the work that it was intended to do. And I have great hope that this commission will recognize that, but more importantly, I hope we can convince our lawmakers in this complex the important connection, as some of you have already mentioned, between health and wealth and our prosperity and the general well-being in terms of why we need to invest in public health. And as I understand it, and I really appreciate so much the great work that our hospital association and other organizations have done to help support public health and our tobacco legislation and so forth to get improvements in our tobacco taxing. But what I've learned through that process is that public health, we've got a long ways to go. We've got a tall hill to climb, and you can probably come up with a lot of other analogies, but it's going to be hard. But with your help and certainly with the help of our leadership of our commission, I think we have a really great chance. 48th in funding, but 41st in terms of our overall health. And as Dr. Box mentioned, this doesn't make any sense. You know, we come from a state that's doing so well in so many other areas. If we look at our where we fit in terms of our economic success and our climate for business and all of the things that make us a great state, this ranking 41st and 48th, and I'm going to show you some more, it just doesn't seem to make sense in terms of how our health status doesn't match sort of the overall sort of position that I think most of us hold as Hoosiers. So this report was really designed to look honestly at our strengths and our weaknesses and to make recommendations. So we did talk to a lot of people about this, and we did a lot of research looking at documents and trying to get it as close to good as possible. But I will also be happy to say that this is a lot of work, and it continues. It needs to have some additional work, and I hope that you've identified additional things you'd like to know after having looked at this report, because it is far from exhaustive, but I hope it gives you a picture. Approximately 3% of our national health expenditures are spent on governmental public health, and as Dr. Box pointed out, you know, we spend a tremendous amount of money on our medical care expenditures. And again, I want to disclose, I spent the first 15 years, nearly 15 years of my life as an administrator. I was a president and CEO of a hospital in Michigan prior to coming to public health. I serve in part on the faculty of our medical school. We are integrated very much with our medical care colleagues. So it's not about dissing the importance of our medical care system, but it is in fact to recognize that what really makes us healthy, we're not paying for. About 3% actually, and that number is pretty generous. If we look at Indiana, I would say it's substantially less. This is, again, this is a busy slide. It's in your report, and we can certainly provide additional information. This is the 10 essential services of public health. It was recently revised. In fact, After almost a decade and a half without being changed, it was changed in just this last year. And one of the things that's important to recognize is that equity is the bullseye. And it recognizes that while we all may suffer, we don't suffer equally. And so issues around disparities in health are important to recognize. And I will tell you that this is a huge issue for Indiana, that we have particularly strong differences in life expectancy. Probably the greatest predictor of health in Indiana, frankly, is your zip code more than anything else. And I'll show you in a moment the very latest data coming from a study that was just published 2 weeks ago, looking at Indianapolis, that illustrates this point. But there are 10 essential services. There are 3 functions of public health, and this was identified in the 1988 Institute of Medicine report. Public health first starts with an assessment. There's a whole lot of work that we do, and that's that whole field around vital statistics and epidemiology and investigation of disease and so forth. And then it goes to policy development. This is one of those areas where public health, our greatest effector arm is policy. That's why we cannot do our work without a strong collaborative relationship with the legislature. And it's also one of the reasons why, as we think about our pandemic response, a number of us are still stinging from some of the changes that were made in a direct response to some of those authorities. But regardless, policy, whether it's good or bad, has a huge impact on public health. And so our responsibility in this commission, as was outlined, is critical, because much of what we need to do can only be fixed through legislative policy work that needs to be a part of the work of our legislature and our governor. And the last piece is assurance. And this is really important because it's often said that public health is the residual guarantor. That is to say, it's nice that some people have insurance, most of us do, but some people don't. And there are a lot of people that are left wanting. And public health's responsibility is to assure that all people can live a long and healthy life and with the opportunity to be healthy. And so again, this is public health's sort of core function, which is so important. And so you see the functions that are related to that. It's important to really dig into these things because frankly, most people, and this was also an important finding from our report, most people that we talk to outside of our public health professionals, but I would suggest to you even within public health in Indiana, had very little clear understanding of what public health is or should be. And that's a huge finding, and I think important to us as we do our work. They don't know what it is that we do, and in large part, it's hard to ask for money for something that people don't understand. Now, here is the expectations of a functioning public health system. This was work done on a national consensus basis to essentially identify what are the things that public health should be doing. And again, I apologize, it may be difficult to see this illustration. It's in your book, and we can get additional information for you. Important, though, to point out is this is not simply what is the responsibility of the state health department. This is the responsibility of public health, and these functions should be available to every citizen, every inhabitant of Indiana, regardless of where you live. It shouldn't, where you live shouldn't depend upon your access to these services, because these services were essentially identified as being so core and fundamental that regardless of where you live, you should have access to it. And it includes things like understanding the disease process and the epidemiology, thinking through environmental public health, maternal and child health, all of these issues that you see here. And what you probably know is that there are very few, and in fact, I would suggest there probably are no health departments that solely, that could meet the full definition of the functioning public health system. There may be a couple that come pretty close, and I'm proud of that work, but for the most part, this is an area where we really have a lot of work to do. So important to point out, and this is also a fallacy for a lot of people, the public health work that we do, that the local health department and the state health department are very critical to our work, but they're insufficient. And and this is work that we did a decade ago, even if you gave the public health department all the money that they felt like they needed to do all the work that they wanted to do, it still wouldn't be sufficient if they didn't have strong relationships within their community. Because public health by its nature doesn't work on its own. It has to have strong linkages and partnerships. And so if you find a strong public health department, you'll find strong and abiding relationships between the hospitals, the government, the non-governmental organizations, the schools, the churches, a whole host of other organizations and individuals within the community that make up the public health system. So this is really important because this is not about governmental employees. This is about trying to develop a function that supports the entire community, and it takes everyone working together to be effective. So the important thing also to do in terms of framing is to say, well, what difference does it make? You know, so in fact, I actually had a person in the presentation I made about a year ago here in Indiana when I announced that we were 48th out of 50 states in terms of our funding. And they said, isn't that great? 48, that's pretty good. I said, well, what do you mean? I said, that means that we're not putting much money into it. And they said, yeah, isn't that terrific? We're not spending money on that. And they didn't really understand that that wasn't a good thing. But they felt pretty proud of that. And it's not to belittle that person, but to say, we've got a long ways to go to be able to get people to recognize what they don't have. And that's the hard part. So in the 20th century, we've gained 30 additional years of life expectancy, 30 years. 25 of those 30 years can be attributed to public health efforts. Interestingly enough, when I do these talks around public health generally, and I ask people, well, we've got 30 years of life expectancy, what do you think caused that? The vast majority of people will tell you it's a new drug, it's intensive care units, it's the way in which we conduct our medical care practice. Most people don't really stop to understand. It's all about what we've done to try to reduce infectious disease. I mean, it's rare today that people die of diarrhea in the United States. Now, there are still a lot of countries where the leading cause of death is diarrhea, but not in the United States. And so, again, most of what we take for granted has been as a result of good public health. And that's probably one of the things that's an important realization for people. So we're going to take a look quickly at public health systems and comparing it to other states and then look at the evidence. So evidence shows, and this is important because this is relatively recent evidence. And although it's intuitively obvious, perhaps it's not really been empirically demonstrated until recently. Evidence shows that when communities invest more in public health, they spend less on healthcare and they live longer. So in other words, it's not just a nice thing to do, it actually can and does provide a return. Now, again, I'm not going to go through each and every one of these things. Let me just tell you that it's one thing to talk about all the states and then how do we fare in Indiana. What we thought based upon feedback from our stakeholders was that what people care about, in large part, what a lot of our legislators care a lot about it's nice to tell me about how New York and California are doing, but how do we compare to our neighbors? And so we said, let's take a look at our neighbors. Those red spots, that's us. And for the most part, we're doing worse than our neighbors in most of these areas, including our overall state investment, our CDC funding, so forth and so on. So our tobacco tax, we're not always the worst, but we're at least second to the worst in almost every area. And what's troubling for me is that much of these areas where we rank behind our neighbors are so key to our overall health. And Brian Tabor has heard you say this probably more times than he'd like, but if you want to know what the real cause of the leading cause of death is in Indiana, it's actually tobacco use. Because if we look at our chronic disease burden, and certainly obesity is increasingly an issue, but if you combine that in particular with our smoking rate, we are really, really behind the 8 ball when it comes to being able to control our overall health status and even in comparison to our surrounding states, to be sure. So we have particularly low rates of vaccination for influenza, childhood vaccines, and adult and elderly vaccines. And perhaps that might be a window to our world for vaccines with COVID. We have one of the highest rates of adult smoking in the nation. Dr. Box mentioned around prenatal smoking. It's alarming to me that we actually have in some counties in Indiana, over 40% of our young pregnant women who are actually smoking, which again, it contributes directly, as Dr. Box knows as an obstetrician, to a low birth weight and complications. And so again, that's another good reason for why we need to be very concerned with this issue. At least 10%, we're at least 10% below the US average for preventable mortality, such as infant deaths, accident deaths, and alcohol, drug, and suicide deaths. That's actually, again, as we look at these numbers, remember the leading cause of death for all people between 1 and 44 is related to trauma, to injury. The leading cause of death for people over age 60, by the way, is falls, which is directly related to trauma. But again, we look at all of these issues. But we do score in the bottom tier nationally on public health preparedness as well. Both Dr. Mays and I have done an extensive work and published in the whole area around public health preparedness. And I can tell you this is one of our areas of concern. So not all illnesses or diseases are equal. And in fact, if we look at the magnitude of the scoring sheets, if you will, so there's a lot of national indices that have been used. Probably the most reliable and most respected is a work that's actually been done by the United Health Foundation. They're the ones that over the last 2 decades have actually ranked the states on health. And you can see this is Indiana's picture. By far the greatest indicator or contributor towards the poor health rankings come from smoking, obesity, air pollution. Many people don't know it, but we rank very poorly for air pollution in Indiana. It's been one of the biggest ahas from people when they look at our overall rankings. But if you look at COPD rates and childhood asthma rates, you see the impact of that poor air pollution rating. And before Hannah has a heart attack, I'll tell you, that says dentist. It's not the problem is not that dentists are killing us. It's the fact we don't have enough dentists, right? And I think really we should broaden that to be oral health, because we do know how important our dental hygienists are in terms of supporting our oral health. This is important. This is brand new information. In fact, if we look at the data, this is, remember I mentioned that our zip code is our biggest predictor. This is Indianapolis, folks. This is where many of us live. And you can see now that there's a 17, within 17 miles, downtown Indianapolis up to Fishers, there's a difference of 16.8 years in terms of life expectancy. So a little baby born today in downtown Indianapolis in that zip code will live on average 18 years less, 17 years less, 16.8 years less than a little baby born in Fishers. And that's, and frankly, it's interesting because we're not talking about a third world country, although I will tell you that that zip code in central Indianapolis compares pretty much the same as some of our third world countries like Uzbekistan and some of our third world countries where we don't imagine comparing. But if you look at some of the statistics, we're pretty close. And if you look up in Fishers, you'll actually find that those rates, that life expectancy in Fishers for that zip code is the same or better than any of the countries that are in the very top rankings for health. So the point of it is it's bad, but recognize it could be better. And we've got some examples not too far from where we're at right now to show us. That's not to just brag on Fishers. It's to say that it's possible for us to achieve the greatness that I think we can achieve. And this is a further picture. It shows the differences in life expectancy just looking at the zip codes. And you can see that the point is that we don't all suffer the same. We suffer very differently based upon where we live. I can also tell you that this work is the second time we've done this, and we're about 24% worse today than we were 5 years ago when we did this. So although we like to believe that as time goes on, things get better, as time goes on, things are getting worse. And I think the alarm bell should be ringing in your head, because this is something we can do something about. This is great work done by a colleague at our School of Public Health, Tess Weathers, and the work that she's actually teased this out to look at some of the indicators and looking at education and income and so forth is really important to sort of get at some root cause issues. But it's really an important part of public health, frankly. So you can see these differences and how they are portrayed. So the important thing again is that the difference between the lowest metro zip code and the highest, 16.8 years. But if you look at Indiana versus the highest US state, it's just 4.2 years, right? So that difference between Indianapolis, downtown Indianapolis and Fishers is 4 times what it is in terms of the difference between the best and Indiana. And if you look at the difference between the highest healthy country and the US, that's only 6.4 years. So we've got huge challenges ahead. And it's, I think, an important context for us. So evidence shows that when communities invest more in public health, they spend less on healthcare and live longer. However, Indiana communities are less likely to be implementing nationally recommended public health activities compared to other states, those foundational public health services in particular. And further, Indiana's communities receive less public health funding compared to neighboring companion or exemplar states. Now, I will tell you, things are a little bit better for us in terms of our funding. Believe it or not, for I think a couple of years, Indiana had the unenviable position of being last in funding from CDC, which was really a hard pill to swallow. Like Judy and I both were at CDC, and we like to, and I will also tell you that CDC is a major, if not the primary funder for most of what is done in public health in this country. I should say, I mean, retract that. It's a major funder. Believe it or not, the largest single funder for public health is not a public health agency. It's actually the Department of Agriculture in the WIC program. The WIC program is the single largest public health expenditure if you look at that. But there was a time that we were the worst. We're not the worst anymore, but we're not a whole lot better. If we look at our overall funding, again, big challenge. So here's the other issue that we found, and it's really an important thing to recognize, and that is that unlike most other U.S. communities that rely equally on state and federal pass-through funding to go to the locals, here in Indiana, about 70% of local public health is paid for by local taxpayers. And that is very different than all the rest of the states. I mean, there are a few states that are similar to us, but I think we're probably one of the states with the greatest lack, if you will, of state pass-through funding to locals. And that shows, because what we see in Indiana is an enormous variation in the kind of services that are provided. And in large part, we leave it to county commissioners to look at a Chinese menu and say, I'll take a little bit of this and a little bit of that, and what can we afford this year? And if we can't afford it, we don't provide it, right? And so a big part of our problem in Indiana compared to the rest of the country is that our funding comes principally from local funding, and then it really depends on what their priorities are, and they have constraints related to property tax caps and so forth. So this is one of the biggest problems that we face, and that relates to really no uniform expectation of public health functions and no real state funding to actually be able to create the state mandates and the uniformity around services, which becomes a very difficult thing. And it's, again, important to say, it's not no state funding. There is state funding that goes, but in comparison to other states, it's substantially less. So although there's value in having direct local connections in every county, the current structure ensures that many of the 94 local health departments are able to provide only a fraction of the necessary public health services and the expertise that should be available to people living in Indiana. Again, I'm going to say something which is sometimes shocking to people, and it is not meant to be denigrating to the public health people that are doing incredibly good work. But the vast majority of people working in public health have no formal training in public health. They do their work based upon the best knowledge that they have. We have a lot of people that come to public health from a lot of different disciplines, whether it's from medicine or nursing or environmental health. But the reality is that most people that are doing work in public health have never had formal training in public health. And Indiana is not unique. Here's the other part of it, though, and Hannah will tell you this, that as we look at the workforce in public health, a report funded actually by the De Beaumont Foundation reveals that almost 40% of the public health workforce within the next 5 years, when the report was issued, which was 2 years ago, plan to leave public health, either through retirement or for other reasons. And so we have a huge impending reduction in workforce of people that, again, remember when most people didn't learn public health through formal training, they learned it on the job. They learned it on the job over many, many years of experience. And when they walk out the door, will really notice their absence. There's a lot of things that we don't have in Indiana that other states do have. And one of the things that we talk about are the information systems. And I know that Dr. Box and frankly, I think every health commissioner in Indiana that I've known has struggled with the fact that we don't have the modern data and analytics necessary in order to do the kind of diagnostic and preventive work and being able to really size up the situation in a quick and transparent way. And so again, we need these data analytics. We need a whole lot more in many of the areas that are listed here. And the list goes on and on and on. But again, all of these things cost a lot of money. And what we tend to see is 94 different ways in which the public health is conducted in our state. Sometimes that works, a lot of times it doesn't. One of the things that we did was we actually, and again, thanks to Dr. Box for her support, we worked with Dr. Mays and actually did a statewide assessment of the functionality of public health. And we were able to identify, this is just taking a look at the regional strengths of public health. We're not showing individual health departments, but to suggest that there's huge variations in the capability, some with very little and some with more, as you can see. But the reality is that we're very uneven. So again, some of the interviews suggested that we really have important opportunities, one of which is to think through how can we work together so that health departments can share resources. And again, absent a huge infusion of resources, and even with a huge infusion of resources, we have very different sized communities, and we have a whole lot of different capacities. And some of our counties, frankly, could not support a full-time epidemiologist or a full-time laboratory person, but they could share it. And the issue is, how can we create the structures by which sharing is both feasible and desirable? And one of the things that we found a little bit surprising in this round of research was actually hearing from the local health department people about how they really understand and appreciate the need to be able to share and would like to have a mechanism by which that sharing could take place. Luckily, the Robert Wood Johnson Foundation has recently conducted some research looking at how across the country, health departments are able to share resources. And, you know, at the extreme, it's consolidation of health departments between counties, which is popular with no one. And for our legislators, it would be like suggesting or mandating that all of our school districts mandate or consolidate just solely based upon population. It's not a very popular idea, but sharing is important. And we need to think through, how do we share resources, and then how do we coordinate that? And most importantly, is from a state level, it's very difficult sitting in Dr. Box's seat to actually direct the activities of the public health in the state, because she has very few levers in which to actually have that happen. There's no good feedback systems, and there's no good way in which to do it. So 6 overarching issues, and I'm done. Public health is not well understood, and it's undervalued. Public health does not have sufficient funding, lack of specific types of public health expertise at the local level. And I would also say at the state level, the state health department in Indiana, in my estimation, is also substantially under-resourced, both in its expertise and in its funding. There's a lack of connectedness and communication between the state health department and local health departments. Again, not because it's their desire to have that lack of connectedness, but because of structural impediments and other mechanisms that don't exist, that do exist in other states, that coordination is lacking. There's insufficient technology and essential infrastructure, coupled with inconsistent data for evidence-based decision-making. Unfortunately, that comes back to bite us in big ways across the state. The local health, public health system is not providing the essential public health services consistently across communities. A lot of things that we could do to change, and I'm not going to spend much time here because this is really going to be the work of our commission. But you can read those recommendations, and they relate in large part to improving funding, coordination, creating opportunities for sharing, creating oversight responsibilities and capacity at the state health department to support and help the local health departments. And again, I know that that's one of the key areas where the state health department would like to help, but lacks the resources and the expertise to do that. And again, one of the things that we suggested, which is coming to fruition with this commission, is this statewide implementation committee. We recommended, this is back in January and written in December, we recommended that one way in which this work could occur was that if we would have a twofer, essentially. If we could tax tobacco, which is the #1 evidence-based way to reduce tobacco use in our state. If we could increase the tobacco tax, we could raise the funding to help support the sufficiency of public health funding, and it would go a long ways. Now, again, it's, I guess, not up to us to decide what revenue source should be used, but as a former state health officer and a dean, I can tell you that, again, tobacco is the #1 cause of death. If we can figure out a way to reduce tobacco use and raise some money for public health, then we've got some success. So again, there's actually some suggestions. If we were able to get, again, I mentioned Dr. Mays' study. If we were able to get to the average of what states spend on public health in his study, which is again a very large number of health departments in that nationwide study, it would cost us about $14 per capita. That's about $81 $81 million in annual investment. It would bring us to the national average level of public health system capacity, and it would reduce medical care costs, and it would reduce we see approximately 890 deaths annually, and add 1 year of life for lower income populations. To get to the highest level, in other words, to that quartile of fully functional health departments, it would be another $55 per capita investment, but that would yield a reduction overall in medical care spending of about $350 million by the end of year 10, and prevent around 3,600 deaths annually, and add about 4 years of life for the lowest income populations. So these calculations are going to be displayed in an upcoming paper, but the reality is we can actually cost out this whole equation in terms of what it would cost and what we would get. So there is a bi-directional relationship between health and wealth, and we've talked about that before. I think Hoosiers deserve the opportunity to live a long and healthy life, and I think that we in this commission have the opportunity to make a huge dent in that. So it costs far less to keep people healthy than to make them well again, but we have to invest in keeping people healthy to start with. So I appreciate so much your attention, and I'm happy to answer any questions you have, but I know I've gone over a little bit, so I appreciate your attention.
Thank you, Dr. Halverson. You know how to bring a cheerful meeting crashing. I'm going to let Chris lead the discussion and next steps section, but before we do that, Chris, I have a sheet here, and you have a sheet down there. Names. I don't know if Dr. Halverson had a chance to put his. Yes. Okay. I apologize for intruding on your personal privacy, but I do think it's important that we be able to communicate with each other as freely as possible. And so I I would like to ask Shane to maybe make copies of these two lists and hand them out. And I would like all of your assurance that this will only be used for your discussion and relationships in this committee. But I think it's critically important that we all be able to talk to each other and that try to follow through as we see necessary. So Shane, if you wouldn't mind, while Dr. Box is leaving this, maybe we can take these and make copies and everybody can have them as they leave, because somebody may want us to talk about this tonight, you know? What time do you go to bed?
Okay, thank you, Senator. So just to run over a few things, again, the designated policy analyst will be doing research in each of these specific educational areas. In October, Bowen Center has graciously said that they will give our first presentations here, and that will be on workforce. And it's not just going to be public health workforce, because we face a tremendous issue in our clinical health workforce also. And this will include a lot of what the Bowen Center has been already working on. So I just wanted you to be aware of that. We may have information that we send out ahead of time so that people can review that information. And I guess what I would say is that in addition to doing things like surveys and giving you this information, this data, maybe having experts come and speak to this, you all are involved in your own groups, whether it's rural health, whether it's minority health, or whether it's the hospital association, in public health as an elected official. And I encourage you to talk with your colleagues in your areas and bring the questions, the concerns, the ideas, the thought process, because you're here for a reason, to represent them and to make sure that we do hear from a broader group of people than just what we might personally have as experience. We are planning and desiring to do listening tours, and I think Senator Finley mentioned that. That will probably, God willing, be in the spring when things are better. We don't want to go out right now and gather a lot of people together, but hopefully we will have been through a lot of our data and information at that point in time, and will be a good time to make sure that we are getting out. And we will probably ask you as commission members if you mind helping us for some of those kind of speaking tours. And it'll be less about speaking and more about listening. But if 3 to 5 commission members could join us at different places around the state, I think that will make sure that we do hear from the expertise that's around the state and the general public. I do want to reiterate, and I think this is really important, that the ultimate work, the ultimate policy, the ultimate recommendations comes from right here around this table in discussions at the meetings just like this. And then we do have hired help to write these individual sections of this. And we will be using our contractors for that. So we will all have a chance to review that input and to give our input into that. I think that's a really important part of this. I do want to leave a little time, I think, Senator, for questions that people may have from the commission now.
And does anybody have any questions or comments? One thing, Dr. Box, have we kind of settled on the idea that we're shooting for the third Thursday of each month as our meeting date from 1 to 3? We'd like to get that kind of on your schedule now.
And Tammy could send out an invitation to everybody. Well, she's not here right now, but okay. So Shane will make sure that happens, so you can all get an invitation to these meetings.
Anybody have any questions or comments?
Hey,
Yes.
Yeah.
I really appreciated the comments by Dr. Box and Dr. Haverson in showing some of the opportunities we could get in terms of really getting us to the next level. But I also would like for us to really start thinking out of the box a little bit. And I noticed that one mechanism for the funding was the tobacco tax, but there's so many other alternative methods that could get us there, whether it's federal funding that might be there, or even foundations that may be getting us there. I think we have to have multiple approaches to this. And I say that we invest a lot. I know I do. with my taxes to the federal government, and I'd like to see some benefit get back to the state of Indiana. And so sometimes we may find some federal funding there that there's a tremendous amount of money, I think, for workforce capacity development and whatever. So I want us to keep our eyes and our research looking at those wonderful opportunities that may be brought to the state of Indiana that could really assist us in this process.
Excellent point, Dr. King. Excellent point. We are watching for those. I know the federal government is getting ready to do some of that.
Yes.
Kim?
Sure. Thank you both, Dr. Box and Dr. Halverson, for your presentations. Tremendous information. I just wanted to highlight one thing that you both alluded to, but I don't know that the term was used. And for future conversations, I just wanted to put it out there today. And that is that idea of social determinants of health. And the fact that we know, as with specifically with our zip code being more important than our genetic code and how well and how long we live, it's fundamentally important, I hope, that this group will understand the role that housing and transportation, education, wages, crime and violence, and on, all of those things that have nothing to do with clinical care settings, but everything to do with health. That we can keep that in mind as we move forward into this work and really thinking holistically about what it will take to change outcomes. Thank you.
Just one comment, something to think about as we go forward, maybe who else we could liaise with or get consult with. For local public health, our funding mechanism is through county councils. And so anything that we might implement or the outcomes of this, we would really need that buy-in. Because they make, as was pointed out by Dean Halverson, if there's 70 or higher percent coming from local money, they make those decisions. So it'd be really helpful. And that is where we struggle sometimes across the state, as a lot of the commissioners and mayors will probably know. So if we could liaise in some way with them, I think it'll help in the end product. Just a suggestion.
Madam Chair, if I could, just to add to that, I mean, it's actually even worse. As Mindy, by the way, has been an enormous help in our research. But one of the things we found out, which is very unusual from my perspective in looking across the country, is that some of our county commissioners actually take it the next step further, which is if the health department is successful in actually bringing in more money than they anticipated, they actually reduce the amount of county contribution commensurate with that. And so the local health officers rightly say, why should I go look for additional grants, or why should I do additional clinical services if all I get is my budget cut? So
just a point of clarification, that again comes from the council. It's not the commissioners at the local level that will pull money. It'll be the council that says, you made money, we're moving it.
Right. And I know one of the things they're trying to do is to reduce that offset in new money, but it is something that's the fundamental or foundational issue. And Senator Kenley, I know you're involved with longtime budget issues, but I mean, that is one of the problems that we face, is it kind of creates an inverse incentive for funding. So.
That's a really good comment. And, you know, there may be some things like that specific observation or comment that a little education in the right place,
right,
like the Association of Indiana Counties meetings, would provide enough of an opportunity that we could sort of change that without really going through the process of having the legislature pass anything. I mean, there are things like that that we need to put on our list that we need to do. Another one that occurs to me is, and of course, everybody looks to the schools not only as a big resource, but as a place where universally people are physically located. And so thinking about how we might ask for some changes in that relationship with the health department might be of value too.
Well, and I think that's why one of our kind of education streams is specifically the relationship of public health to education and to schools, because they have been, that relationship, Mindy can tell you, I know, has been so critical and so important in addressing this pandemic. And that's something that we already do a lot of public health in our schools, just with, immunizations and other things. So it's really important that we do formalize that and make sure also that there are not disparities in that across the state of Indiana. I will say that the State Department of Health, knowing that a lot of funds were being supplanted around the state, began writing all of our contracts where that the signage said that the funds could not be supplanted. So that the money we were giving them could not be used to supplant other money that they were already being given.
Many times just an awareness though is a big part of it. And also as we think toward the end product of what we want to recommend and try to get the legislature to help us with, if we have other ways that things can be accomplished, like relationships with the schools or relationships with local government, or the theory of not supplanting and those kind of things, if we can establish that we're trying to ask everybody to participate in something that I think if they heard Dr. Halverson's presentation would be a logical, important goal for the state to adopt. That way it sort of takes the pressure off the legislature saying, gee, you're the only one that can solve this problem. And we want you to do everything. So if we can begin to formulate a presentation that has that kind of strength and balance, I think would be a good goal for us to think about as we begin putting together our thoughts.
Oftentimes when we develop policies or plans or ways to approach different health issues, we'll break them down into these types of things have to be done legislatively, and these could be done through education or outreach or other things, but still lay it out so that we know what the whole package looks like.
Sure. Yes, Brian.
I'm just going to say, won't put him on the spot now, but for a future meeting, I think it'd be really interesting to hear from Dr. Monroe, Dr. Halverson, certainly others too. But I think with the perspective of having done public health in Indiana, but also done it in other states, I think, clearly the data, we see a lot of weaknesses and there are these structural deficiencies, but I think there are also some strengths. Senator Kemley mentioned the university system. I think about our health information exchange, which is statewide, which is not something that other states have. So that might be a good thing to do early on, or identify some of the unique strengths that we can build around going forward instead of, thinking about reinventing them.
Yeah, that's a good comment, Brian. Dr. Monroe, I think when I used to go to national meetings on budgeting and tax policy, there were always a few states that really stood out as they kind of really got it together on this subject to that subject. And so maybe you could help us to find some of those, and maybe we need to hear from somebody.
Yeah, I would just add, Brian, I think you're spot on. I certainly like to approach problems starting with the strengths. Let's build on the strengths of what Indiana has. And I think, Dr. Keene, what you were saying about we need to think out of the box a bit. Because there are solutions that we may not have thought of, and collectively we will if we dive into the what other states have done, as you've said, and what we can learn nationally and elsewhere.
Yeah.
Yes.
I think I was alluded to by some of the presenters, and I appreciate their input. And this is actually something the State Department of Health has done well the last year, is helping the folks in the grassroots better explain why we're doing certain things and why we're approaching things the way they are. So an education program, I think it came out with Dr. Halverson's presentation, a lot of folks don't even understand what's public health. So if as we are figuring out how to fix the system, a key component of education and communication, how does the local health officer communicate with his council and his commissioners or his school boards, so that we get from A to B where we need to be. So I know, there's a lot of hardworking folks, but, maybe they didn't have, communication background in college or an MBA program.
And I think that one thing I said on the way over here is that right now, many people's impression or view of public health is mask mandates and vaccine mandates. And that has not been, nor is it, it is a small percentage of what we've done. It's just been so out there this past 19 months that we need to bring the focus back to really what public health is. and what it is we're trying to address. So that people don't have the fear that we're just trying to be able to have mask mandates all the time or mandate vaccines.
Hannah?
And I do think that as we're having these conversations, public health can't do public health alone. So I think as we're looking to formulate recommendations and policy solutions, collaboration, coordination, and integration across health systems, hospitals, education systems, workforce development, that absolutely has to be front and center and built in and woven into the fabric of any recommendations if it's going to be sustainable and fly and make a significant impact for Indiana.
Comment that I would make, new county commissioner in Hendricks County. I'm learning quickly, but there's a strong relationship between the county commissioners, the county council, and the county health department, where the county health officer in Hendricks County makes a monthly report to both the county council and the county commissioners and has a close working relationship with them. I'm assuming that doesn't happen in every county across the state of Indiana, but there is a close working relationship there. And I think the Association of Indiana Counties, AIC, could be a help as we look at all of this as well. And then the last comment that I would make, which is kind of going down a different path completely, and I think Mayor Courtney of Madison alluded to it briefly when he introduced himself, but personal responsibility for health is a part of what has to happen as well. And if individuals, no matter what zip code they live in, your map showed, and I'll tell you where I grew up as a kid. I grew up in Mars Hill in Marion County. When I was dating my wife 52 years ago, when I was dating my wife, she had a roommate who was a social worker in Indianapolis. And when she found out that she was going to go out with this guy from Mars Hill, she said, "You don't want to go out with him." And because of the implication of that zip code and the people living there and so on. So it doesn't matter. I mean, it matters the zip code, yes, but personal responsibility, I think, has to be considered as well. I think that's important. So I'll be quiet. I'll get off my soapbox.
Chris, it's 3:05.
Oh.
And so if you would like to, anything else to wrap up or?
No, I just wanted you guys to know we'll be talking workforce in October, third Thursday. I'll have Tammy send out invites to everybody. We may have some information that the Bowen Center wants to share ahead of time, and we'll try to get that out to you so you have the time to review that prior to the meeting. And I just thank everybody for your time today.
Thank you very much.
Thank you.
Yeah, sure.
I just wasn't, I haven't seen that. Is that out?
Good for you. Take a family. Oh my God. My favorite place in the world. No. Yes, we did too.
Yeah.
I wondered when I was.
I love Courtney.
Just for vacation. Yeah.
Perfect. You guys are the best.